Oral cancer management. Diagnosis of oral cancer is by punch biopsy. It is done by special punch biopsy forceps. Wedge biopsy. It is done by cutting tumor by blade. Orthopantomogram is used to assess mandibular erosion. Limitations are, early erosions can be missed. At least 30% of bone resorption should occur before visible on OPG. It is not sensitive for central arch of mandible due to spinal overlap. CT scan is preferred imaging for most cases of oral cancer. It is good for assessing depth of tumor, especially in cases of T2, T3, T4. Nodal staging is optimal. Early mandibular erosions can be detected, hence decision for some form of mandibular resection can be undertaken. Puffed cheek approach, PCT, increases visibility of small buccal mucosa and gingivobuccal sulcus lesions. Important for diagnosing ITF involvement. HRCT thorax is done for diagnosing lung mets in T3, T4 and node-positive disease. Accuracy decreases due to dental alveolar disease and artifacts. What is puffed cheek technique in CT scan of oral cavity? Puffed cheek is blowing out cheek like before blowing candles, but patient has to hold this position. This approach moves buccal mucosa away from alveolus, hence gingivobuccal sulcus opens up. Thereby any tumor in gingivobuccal sulcus can be adequately visualized. MRI is better for soft tissue visualization. Contrast MRI is modality of choice for tongue cancer. It is better than CT for small primary in oral cavity. It is excellent for viewing perineural invasion, infratemporal fossa involvement. However, it overestimates bone cortical erosion while CT underestimates. PET-CT at initial diagnosis is indicated in locally advanced tumors, T3, T4, node positive. They have an approximately 20–25% chance of having distant metastasis and approximately 8% chances of having synchronous second primaries. It is also used to assess response to chemoradiotherapy. It can be used to detect recurrence and assess response to therapy. Most common form of PET scan is FDG scan. FDG stands for fluorodeoxyglucose. In glucose, one oxygen is replaced by fluorine-18, which is radioactive. In cells, glucose enters through special receptors called GLUT receptors. These receptors cannot differentiate between glucose molecule and fluorodeoxyglucose molecule. Glucose molecules undergo conversion to glucose 6-phosphate by a glycolytic enzyme. Similarly, FDG also converts to FDG6-phosphate. But next enzyme recognizes difference between glucose and fluorodeoxyglucose. So FDG gets trapped inside cells as FDG6-phosphate and emits radiation which is detected by gamma camera. Tissue with high metabolic activity like tumor tissue have more uptake of FDG, hence emit more radiation. Brain normally is hotspot due to high metabolic activity. Hence in case where brain mets are suspected, MRI brain is preferred imaging. Similarly, heart may also be hotspot. Bladder may appear hotspot due to excretion and accumulation of FDG dye in urine. Oral cancer spreads usually in a predictable fashion with first spread to neck nodes and then to further distant areas. Most common site of distant mets in oral cancer is lung. As per TNM staging, depth of tumor measured by pathologist has important role in staging as chances of nodal mets increases with depth of tumor. Any tumor with more than 4 mm depth is risky. T4 is advanced disease with T4A operable and T4B usually inoperable. How is masticatory space different from infratemporal fossa? Muscles of mastication, namely temporalis, lateral pterygoid, medial pterygoid, masseter, are contained in a space called masticatory space. This space is a fascia-bound space extending on both sides of mandibular ramus. Infratemporal fossa is present behind maxilla and is a part of masticatory space. Mandible has two process, condylar and coronoid process, with a notch in between called sigmoid notch. A horizontal notch through this notch divides masticatory space in two parts, upper containing mainly temporalis and lateral pterygoid muscle, and lower containing mainly medial pterygoid muscle and masseter. This distinction is important as tumor involving lower masticatory space are more amenable to resection and thus better survival outcome. Among nodal staging, worst factor is extracapsular nodal extension (ENE). When is oral cancer case inoperable? Erosion of skull base, encasement of internal carotid artery, involvement of mediastinal structures, involvement of prevertebral fascia, extensive skin edema, extending above zygomatic bone, fixed lymph node, distant metastasis, non-regional nodes present, poor performance status. In some cases like fixed node, extensive skin edema, there is a role for neoadjuvant chemotherapy, following which attempt at resection can be made if good response is there. Hence they are relative contraindications. At least 1 cm of visibly and palpably normal mucosa around the tumor is taken as margins while resection of primary cancer. At least 5 mm of pathological free margin is termed as negative margin. Why at least 1 cm margin is required if only 5 mm of free margin pathologically is considered negative margin? Because of tumor shrinkage, soft tissue when cut shrinks by 10–20% immediately, and further shrinkage occurs when formalin is added as preservative. By the time tissue reaches pathologist, shrinkage may occur up to 30%. Therefore 1 cm of margins can become 6–7 mm only. It is important to take 1 cm circumferential 3D margin. That is, deep margin should also be at least 1 cm. Imaging can help in planning resection and achieving adequate deep margin. Some surgeons may prefer 1.5 cm margin in tongue, as there is intermittent contraction of muscle fibers of tongue when cut with cautery, hence margin error may occur. What if there is mandible lying within 1 cm of margin around tumor? If tumor is within 1 cm of mandible but not abutting mandible, periosteum can be taken as extra margin and bone be spared. If tumor is abutting mandible but no erosion with minimum paramandibular disease, marginal mandibulectomy can be done where only part of mandibular border adjacent to tumor is removed, preserving lower margin, hence contour. In cases of mandibular erosion, large paramandibular disease, or if marginal mandibulectomy is contraindicated, segmental mandibulectomy is done. To repeat, if tumor is within 1 cm of mandible but not abutting mandible, periosteum can be taken as extra margin and bone be spared. If tumor is abutting mandible but no erosion with minimum paramandibular disease, marginal mandibulectomy can be done where only part of mandibular border adjacent to tumor is removed, preserving lower margin, hence contour. In cases of mandibular erosion, large paramandibular disease, or if marginal mandibulectomy is contraindicated, segmental mandibulectomy is done. What if tumor is close to skin or involving skin? If tumor is involving skin or close to skin in imaging, then removal of skin taking 1 to 2 cm margin is done. It is to note that edematous tissue and skin can harbor cancer cells, hence margin must be taken beyond edematous skin. What are various types of mandible resection? There are mainly 4 types of mandibulectomy: segmental mandibulectomy, marginal mandibulectomy, hemimandibulectomy, reverse marginal mandibulectomy. Segmental mandibulectomy is removal of a part of mandible but sparing at least condylar process. Marginal is preservation of continuity of mandible by removing only part of mandible border. Cut may be horizontal or oblique. Hemi means removal of part of bone with both process. usually done in height disease when erosion is close to process or involvement of inferior alveolar nerve. Reverse marginal mandibulectomy is done for level 1 lymph node which is fixed to mandible. Here lower border of bone is removed. Why is marginal mandibulectomy contraindicated in edentulous mandible? At least 1 centimeter of mandible height is required for stability of bone. In edentulous mandible, the height of mandible decrease with increasing age plus. There is age-related osteoporosis. Hence if marginal is done then there would be chance of residual mandible fracture either during surgery or later on. What are other contraindications of marginal mandibulectomy apart from edentulous mandible? Bone erosions. Radiation-induced osteoporosis. Inability to preserve 1 centimeter of mandible after resection. Large paramandibular disease. How do you manage oral cancer with operable neck nodes? Palpable nodes, especially if not hard and mobile, may be due to infection. Hence palpable node may not be positive and vice versa. Any sign of fixation of node to adjacent structures or hard consistency indicates positive node. High-resolution USG may help in diagnosing tumor whose nodes. Signs of positive neck nodes, if palpable on scan, are greater than 10 mm in short axis, loss of fatty hilum, central necrosis, cystic nodes. Normal nodes are usually flat and oval. They are flattened as there is pressure of surrounding tissue. In case there are tumor cells in nodes, they will grow in all directions in node, hence changing to spherical shape and increase of short axis diameter. In case of positive nodes in neck, modified radical neck dissection is done, which involves removal of level 1 to 5 and sparing of 1, 2 or all 3 structures, namely sternocleidomastoid muscle, spinal accessory nerve and internal jugular vein. In cases of extensive neck disease where nodes are adhered to these structures, removal of all 3 with level 1 to 5 is called radical neck dissection. What if no neck nodes are enlarged? Except in very early cancer, it is generally preferred to remove few initial levels of neck to detect and remove microscopic disease. Selective neck dissection is done mainly supraomohyoid neck dissection, level 1 to 3. Extended supraomohyoid neck dissection, level 1, 2, 3, 4. In cases of cancer tongue, there are reports of direct spread of cancer to level 4 by skipping earlier levels in around 15% cases. Hence in cases of cancer tongue with no neck nodes palpable, extended supraomohyoid neck dissection is preferred. In rest of oral cavity with and 0 neck, supraomohyoid neck dissection is done. When is contralateral neck dissection done? In cases where tumors approach or cross midline or midline, central tumors. Opposite side neck dissection is also done. Extensive nodal metastasis on one side increases chances of metastasis on other side even though tumor is away from midline due to opening of new lymphatic pathway caused by blockage of old path by nodal bulk. Hence in these cases also opposite selective neck dissection can be done. It is to note that any positive node in opposite neck must have modified neck dissection done. Selective neck dissection is done only in N0 cases. What to do after surgery of tumor, resection of primary, with neck dissection with reconstruction is complete. Adjuvant treatment is planned. Purpose of any adjuvant treatment is to eradicate microscopic residual disease in primary tumors with adverse pathologic features. Radiation is indicated in cases of T3, T4 disease, presence of LVI and PNI, close or positive margins, nodes with extracapsular nodal spread or multiple nodes positive. Extracapsular nodal spread is said when tumor breaches node capsule into the surrounding. It is considered one of the worst prognostic factor in resectable oral cancer. Chemoradiation is given in some specific setting. Indications of adjuvant chemoradiotherapy are positive tumor resection margins, extracapsular nodal extension,